Hello, hi there. Good evening. Hi, Derek.
Hi.
Good evening.
Good evening.
Dr. Tazar. Good evening, Dr. John.
Good evening. Good evening.
Hi there. Good evening. Thanks for being with us today, and welcome everyone to the first webinar for this year. And we are honored that we are going to have our friends from Cleveland Clinic Abu Dhabi with a distinguished speaker that we are going to host today. So before doing the welcoming, I would like to address a few things. I'm happy and honored to welcome all distinguished guests and delegates to the first chapter of MENASO Education Academy Cerebrovascular Grand Round for 2020. We had a wonderful year last year with more than monthly webinars and MENASO Congress, which has been done in Bahrain this year. The webinar series in 2020 have been fruitful and rich with presence of 17 scientific committee members and 16 MENA regional speakers and 10 international speakers with more than 13,000 participants for more than 78 countries worldwide. These are a landmark for a stroke in the Middle East, and we are so honored that we are able to do this to increase the education about stroke in the MENA region, to involve more people with advanced treatment that they are delivering at the level of the region. MENASO and the Grand Round that we are conducting in a monthly base has been achieved a good feedback from our colleagues in the region. Many neurologists, stroke specialists, physiotherapists, occupational therapists, internal medicine and family medicine with a neurosurgeon who's giving us a good feedback about these type of webinar. And we are looking to continue this for 2020. I will not forget that these activity is endorsed by the World Stroke Organization, WSO, and American Heart, American Stroke Association. No further delay. There will be a question and answer at the end of this session, as usual, and the audience can use the Q&A box for these questions. And by the end of the session, we will have more than 15 minutes to 20 minutes to answer all your questions. I would like to welcome my friend and co-chair, Professor Derek Krieger. Professor Krieger is a neurology professor and neuroscience, and he is currently at Parkview Med Clinic. He worked in different places, including Heidelberg, Germany, Texas Medical Center in Houston, and he's the founder of Cerebrovascular Disease Unit and Stroke at Copenhagen University. Dr. Derek has been in UAE for the last 6 years, and we work together at the level of Dubai and North Emirates to build the stroke service. And I can say pages about Derek, but I would like to welcome him and to start introducing the speaker. Welcome, Derek.
Thank you, Sohail. Yeah, it has been a pleasure the last 6 years with you and all the others. And I think this initiative that you stamped out, the MENASO Grand Rounds, is amazing. And I'm just checking here. We have 763 participants. No words spoken yet in terms of our stellar speakers from the Cleveland Clinic. The Cleveland Clinic is for all people who are not from the region here, is an amazing place. Whoever is going to visit Abu Dhabi should take a visit of the Cleveland Clinic. It is something between a hospital and a temple or a mosque. It is an incredible building, and it's very, very well done. And of course, the people that work there in the stroke center are stellar. And we have today 2 of them. And they also, they just don't talk about thrombectomies and this kind of stuff. Everybody does this. They actually chose some very, very interesting and complex topics, both of them. And I have the pleasure of introducing the first speaker, Dr. Syed Irteza Hussain, who is the Department Chair of Neurology in the Neurological Institute at the Cleveland Clinic in Abu Dhabi and a consultant neurologist with 20 years of experience. He completed his medical degree from Aga Khan University. Then he underwent extensive postgraduate training in the United States. He is American board certified in neurology, vascular neurology, neurocritical care, and neuroendovascular surgery. Dr. Hussain joined Michigan State University as an assistant professor in 2009, where he helped to establish a 24/7 neurointerventional surgery service and fellowship training program. Subsequently, in 2011, he was appointed the medical director of the stroke program at Michigan State University and is affiliated in its affiliate Sparrow Healthcare System, and was promoted to associate professor in 2014. Dr. Hussain was awarded the Physician Leader of the Year award in 2015 by the Sparrow Healthcare System in Michigan, and also his teaching awards recipient from the University of Wisconsin Medical School. Dr. Hussain completed a couple thousand cerebral angiograms and neuroendovascular procedure during his career, and he's going to talk to us today about ischemic stroke of unusual etiology. Dr. Syed Irteza, the floor is yours.
Thank you very much, Professor Krieger, for that kind introduction. And also, I would like to thank Dr. Sohail Al-Rukn as our MENASO president and leader in the region for promoting these educational activities, especially in such hard times. We've been here at the Cleveland Clinic for the last 5 to 6 years, and we've really enjoyed our relationship with our colleagues in Dubai and the rest of the UAE and the region. And I think this is a great platform for us to all interact and learn from each other. So without further ado, I will start off with the first topic. So the format for this educational rounds was obviously case presentations. And so I'm just going to share my screen. Okay, so this is the case. So 54-year-old previously healthy lady, no significant past history except for recurrent UTIs, was found to have ureteropelvic junction kind of stenosis, placed initial stent in August 2019 and then into 2020. So overall, things have been fine. She had a stent replacement in September of 2020. And around about that time, family began to notice that she was having progressive cognitive decline. Initially, just minor lapses in memory. And then they began to notice, okay, suddenly she was having problems with gait. She kind of stumbled along for some time until around December 2020, when after a repeat stent replacement, she developed significant worsening of cognition, and this time with impaired level of consciousness and ability to walk by the end of December. So over a month, progressive decline. A week prior to presentation, there had been drastic worsening, where she was not talking or eating adequately. Past medical history, as I said, wasn't really significant. However, there had been a 20-kilogram weight loss over the last year for unexplained reasons. On examination, initially the patient was somnolent, opened eyes only to voice, grimacing to pain and moaning. She had no coherent speech. There was spontaneous movement of the right upper and lower extremity, and there was some left-sided weakness, but was able to withdraw to pain. There was diffuse hyperreflexia with bilateral clonus, sustained on the right, non-sustained on the left, and plantar responses were upgoing bilaterally. She was unable to participate in sensory testing and could not stand or ambulate without assistance. So we're going to go over the external hospital investigations first. So this was in a different country. MRI Brain at the time showed T2 FLAIR hyperintensities identified in the gray and gray-white matter junctions of bilateral cerebral and cerebellar hemispheres. These areas showed restricted diffusion, suggestive of acute infarctions. There was no hemorrhage. There was no pathological leptomeningeal enhancement. Time of flight MRA was carried out, showed significant thinning of the A1 and A2 segments, distal segments not visualized, no significant stenosis in the rest of vessels. So here are the images. So these are diffusion weighted imaging. And as you can see, areas in the cerebellum bilaterally, and then also in the hemispheres, you can see scattered areas almost in a watershed pattern noticed bilaterally, slight predilection towards the right compared to the left. On FLAIR imaging, I just wanted to show this image, and we'll come back to this later, that there was areas of T2 confluence changes, which you can see, which are involving cortex and also coming down into the subcortical white matter. This was her MRA at the time, and as you can see, overall, the proximal vessels look okay. However, at the MCA bifurcation, there's some attenuation of the vessels. However, you know, within the realm of MRA sensitivity, this was at the time called probably within normal limits or artifact of imaging. The patient's MRV was normal. She underwent echocardiography for the stroke, which was normal. As I said, no underlying vascular risk factors. A1C was normal. LDL was slightly elevated. COVID testing at the time on a repetitive basis was negative. Because of the weight loss, she underwent CT chest, abdomen, pelvis, and briefly, nothing remarkable standing out except for some hypoplasia of the adrenal glands and the previously noted ureteric pathology. There was some thickening of the gastric wall, and this was pursued with endoscopy and biopsy, and it did not reveal anything, just some non-specific gastritis. So at the time, a DSA was carried out as well. And visualized major vessels are mildly tortuous, showing mild atherosclerotic changes. This is the report. Mild irregularity seen in distal branches of both PCAs could be secondary to atherosclerotic changes. Possibility of vasculitis is less likely, no filling defects. So after this, the diagnosis, the presumptive diagnosis at the time was ESA, so embolic stroke of unknown source. The patient was started on Xarelto and atorvastatin and subsequently discharged. The patient, though, continued to rapidly deteriorate over 4 weeks. And at that point, a second opinion was sought, and she was brought to our institution. When we first saw her, she was minimally responsive. She did have brainstem reflexes intact. She overall was in an akinetic, spastic quadriparetic state with diffuse hyperreflexia. So this is the MRI scan that we carried out, and this is the first one we have. So the top here, we have areas of restricted diffusion, which are also showing restricted diffusion and ADC map. These are the flare changes, and you can see that there's some confluence of these flare changes. And when T1 with contrast did show enhancement, and initially this was called that these could be subacute strokes and enhancing, but I'd like to focus your attention to some of the nodularity that is noticed back here, as well as this nodularity within the cortex that you can see in some of these lesions. This was the MRA that we did. Now, in comparison to the prior MRA, we felt that, okay, previously the distal vessels were likely attenuated, and here they look a little bit better, but you know, there could be difference between imaging modalities and from machine to machine. But we did also carry out MRI brain with vessel wall imaging, looking for enhancement. And the MRI brain vessel wall imaging did not show any areas of abnormal enhancement within the proximal vessels. As you may know, MRI brain vessel wall imaging is increasingly being used to look for inflammatory versus non-inflammatory vasculopathies, to try and differentiate between them, but the sensitivity of this falls off as we go into the distal blood vessels. She underwent Transthoracic Echo, TEE, which were normal, as well as CSF analysis, which was completely normal. By the way, this was also carried out at the external facility, and repeat hypercoagulable and autoimmune screening was negative. We reviewed the external DSA through an online platform. Unfortunately, I don't have those images available to show, but we felt that there was attenuation of the terminal vessels. So at this point in time, we decided to proceed with stereotactic brain biopsy of one of the right frontal enhancing lesion. And this revealed cortex with rare intravascular atypical cells that were CD20 positive, proliferating, suggestive of intravascular lymphoma. There was no evidence of vasculitis associated with this lesion. There was beta amyloid positivity, though, in diffuse plaques, but negative within the vessels. And this is just an example to illustrate. So H&E staining, and then we can see the CD20 lymphocytes in an intravascular portion as consistent with evidence of intravascular lymphoma. So at this point in time, treatment was initiated. We actually had to collaborate with our colleagues at an oncology center here in the UAE. And the patient underwent PET scan. No other signs of systemic illness were seen. She underwent intrathecal methotrexate followed by R-CHOP for 6 cycles. Her PET scan improved. However, upon repeat examination and evaluation a couple of months ago, she still had a very poor clinical state, modified Rankin scale of 5. She has retained level of consciousness, but is akinetic and most days is mute. And this is her most recent follow-up MRI scan. And as you can see on T1 with contrast, the prior areas of involvement have basically burned out. We have large areas of black holes, but on the periphery, you can see nodular enhancement that is still there. This nodular enhancement had been stable, but as there had been no clinical sequelae related to this, and because of the intensity of the chemotherapy, right now additional chemotherapy is on hold. So, CNS intravascular lymphoma. It's a rare subtype of diffuse extranodal large B-cell non-Hodgkin's lymphoma. It is relatively rare, but it's not unheard of, and it does have a predilection for the CNS. There's intraliminal proliferation of neoplastic lymphoid cells, and it typically affects the small and medium vessels of the CNS. The spectrum of manifestations is usually cognitive decline, dementia, rapidly progressive dementia, headache, seizures, but you can also have stuttering symptoms that look like stroke-like episodes. So how does one reach a diagnosis? I think first and foremost, you need to have a high index of suspicion. Younger age, though it can present later in life in 50s and 60s, but the absence of vascular risk factors, stuttering symptoms with progressive cognitive decline. Some patients can have an atypical skin rash, and actually even in patients without evidence of rash, when they undergo biopsy, in up to 80% of patients, you may find involvement of skin. Adrenal enlargement can be a tip-off, but one of the big MRI findings that we need to focus on, and which was present in our case in retrospect, is the presence of confluent white matter lesions. And so if we look at these MRI changes, so this is the first scan on the left, is the first flare sequence that was done in a coronal fashion from the external scan back in the original scan in September of 2020. And then this is the follow-up scan on the right in our institution by February. And you can see this predilection for kind of a T2 confluence that is happening almost in the border zone areas, but can also involve cortex. And whenever you see those type of findings, you have to have a high index of suspicion, especially if there is no vascular risk factors. And unless you have a high index of suspicion, this is what you're going to end up with. So as the disease progressed, there was areas of burnout, but that T2 changes, the confluence kind of expanded over time. I just wanted to, as an interventionalist, I just wanted to offer our 2 cents on angiography, especially when you're considering such a diagnosis of CNS intravascular lymphoma. You have to remember it typically involves the very small branches. And you have to have a trained eye, high index of suspicion to be looking for this. I can tell you, I'm pointing at a vessel here that looks attenuated, but that was discovered in hindsight. A lot of times a vessel this size may just be overlooked, as was in this particular case. So a DSA can be read as normal. And maybe even the DSA is completely normal because the vessels involved are very small. So the gold standard for diagnosis is biopsy, and however, sometimes it's carried out too late. And actually, a lot of case series, the diagnosis is made on autopsy. In one case series, I saw it was up to 50% of cases. So unfortunately, most of the times the diagnosis is delayed and or it's postmortem. The treatment has been standardized. Review of the oncological literature. Standard treatment is a combination of R-CHOP with intrathecal methotrexate. There are other protocols that have been explored. Methotrexate followed by XRT. However, the survivability has not been seen as the same. And one interesting treatment protocol that I saw involved unfractionated heparin. And the CD20 proliferated cells apparently can develop molecules on their surface that bind with heparin. So they have these adhesive molecules that bind with heparin. So when unfractionated heparin is combined with treatment, apparently the response can be even better. But obviously this has to be taken into account because some patients may also have hemorrhage as a presentation, but we have to take that into account and discuss this with an oncologist when we're treating these patients. So what's the take-home message? Atypical stroke with a progressive decline, atypical MRI findings, nodular enhancement. Our neuroradiologists really hammered home the message with regards to nodular enhancement in stroke, white matter confluence lesions. Remember, angiographic findings may be non-diagnostic and high index of suspicion to pursue an early brain biopsy. The disease can go into remission. However, the neurological recovery depends on the extent of injury. So unless it's picked up well and treated aggressively up front, we may put the disease into remission, as is the case for our patient, but the degree of neurological disability may be irreversible. So I'll stop right there, and I'll be happy to take questions. I believe I'll defer to the panel. Maybe we're taking questions at the end of the talks.
Yeah, thank you. Thank you very much, Etesa, for this interesting case. Yeah, it would be better to discuss everything at the end. And I have the pleasure to invite the second speaker who's taking up a very interesting topic. Dr. Sebi John is a vascular neurologist and neurointravascular surgeon, also at the Cleveland Clinic in Abu Dhabi. He completed his neurological training, including neurology residency, vascular neurology fellowship, and endovascular surgical neuroradiology fellowship at the Cleveland Clinic Foundation in Cleveland, Ohio, USA. Subsequently, he joined the Cleveland Clinic in Abu Dhabi as a consultant neurologist in 2018. He is currently clinical associate professor of neurology at the Cleveland Clinic Lerner College of Medicine in Ohio, Cleveland, and adjunct clinical associate professor of neurology at Khalifa University College of Medicine in Abu Dhabi. Dr. John has extensive experience in the medical and interventional management of cerebrovascular disease. He's an active researcher and has been an investigator in numerous international cerebrovascular clinical trials. He has to his credit more than 60 peer-reviewed publications and book chapters in the field of stroke and neurointerventional surgery. And he is on the board of directors of the MENASO, Middle East, North Africa Stroke and Interventional Neurotherapeutics Organization, and the UAE Vascular Neurology Chair for the Mission Thrombectomy 2020 Plus. He's an active reviewer for multiple journals and is on the editorial board of Clinical Neurology and Neurosurgery. Dr. Sebi is talking about the endovascular management of cerebral venous sinus thrombosis. And I'm very interested to hear what he has to say. Dr. Sebi, the floor is yours.
Thank you very much, Professor Krieger, for the kind introduction. And thank you, Dr. Suhail, for giving us the opportunity. We're very honored. And I see your participants has crossed 1,000, which is amazing. Let me just share my screen. Okay, thank you. So I do not have any relevant disclosures. I'll stick to the case-based presentation, but I would like to show you a few cases to give you a sense of the complexity of this disease and how variable it can be. So the first case is a 20-year-old, very healthy Indian gentleman who had a history of 5 days of severe headache. And he presented to our emergency room with seizures. He was actively seizing, and he went on to be refractory seizures and subsequently into status epilepticus. His examination, when he came in, he had a GCS of 8/15. Cranial nerves, his pupils were reactive, no focal deficits that we could identify prior to his intubation. And his CT scan was as seen below. This is a non-contrasted head CT, and you can see large areas of hyperdensity, which are seen on the non-contrast CT along the left transverse sinus. You can see along the straight sinus, and here in the very high superior sagittal sinus and the draining veins. I can tell you that the CT venogram was done at this point, and it showed extensive thrombosis involving the superior sagittal sinus, bilateral transverse and sigmoid sinus, and even the straight sinus. So patient was intubated. He was started on antiepileptics, immediately started on IV unfractionated heparin, including a bolus, and subsequently continued on an infusion therapeutic dose. This was a follow-up MRI also on day 0. And you can see the extensive areas of loss of the sinus filling. And again, you can see this is the AP and lateral, the superior sagittal sinus, bilateral transverse. You can see a little bit of the sigmoid over here, but essentially a case with extensive thrombosis. So he was with therapeutic anticoagulation for 48 hours as documented by therapeutic PTTs. He was not having any clinical seizures, and the EEG confirmed that there was no electrographic seizures, but the patient did not improve. At the end of 48 hours, he also started to have some focality with more left-sided weakness, and his GCS was about the same, maybe even worse, to a 7. So an MRI was repeated, and you can see this is a diffusion-weighted image, and this is the corresponding ADC, and he was starting to develop infarct. This is a flare where you can see the hyperintensity, and the last is the SWI sequence where there is still no hemorrhage, but in this gentleman, he's developing ischemic infarcts. So what would be your next step? Just keep this in your mind, and I'll come back to these cases. Case number 2, this is a Pakistani gentleman. He was healthy, 51. He did have some pneumonia 2 months back, unknown whether it was COVID. And he presents with 3 days of headache and visual impairment. This was at an outside hospital where they did a CT, and he had superior sagittal, right transverse, and sigmoid sinus thrombosis. And at that time, he had a right parieto-occipital venous infarct. I don't have these images. He was started on therapeutic anticoagulation, this time with low molecular weight. They chose enoxaparin, and he was doing okay. But on the 4th day of therapeutic anticoagulation, he became worse. He got agitated, left-sided weakness. His exam was a GCS of 13, slightly confused. He was cortically blind, and he had mild left-sided hemiparesis. So this was when he got to us. Remember that he has been on therapeutic anticoagulation for 4 days with right transverse sigmoid and superior sagittal sinus. And here you can see the venous infarction, the edema, and now you can see a new area of hemorrhage in here. And you can also see that he's starting to develop some hypodensity on the contralateral side, the left side, which probably explains why he's cortically blind. Just another cut showing these same things. So his 4 days therapeutic anticoagulation, what would you do with this gentleman? Third case, this is a 50-year-old gentleman. He's healthy, a Filipino gentleman, 2 weeks of headache. And on the day of presentation to the emergency room, he had right-sided weakness. He was absolutely intact in terms of GCS, 15 out of 15, but he had very mild drift on the right hand. This is a non-contrast head CT. You can see the high sagittal sinus. There is a hyperdensity, also including the cortical veins. And if you look carefully enough, you see there's something going on over here in the left posterior frontal lobe, probably some edema. A CT venogram was done as part of our routine stroke protocol. Also involves a delayed image, and again showed extensive sinus thrombosis of the superior sagittal sinus and bilateral transverse sigmoid sinuses. The deep sinuses were spared. Right in the emergency itself, 60 minutes later, he starts to have a new seizure. It was focal with secondary generalization. And thereafter, he became extremely agitated. His airway was being compromised, and he had to be intubated. He was, of course, loaded with anti-epileptics. So this is a scenario where it's a fresh presentation, very early deterioration, not started on anticoagulation, and he's bled. What would you do in this case? And the last case I want to say is a 29-year-old female who's 6 weeks pregnant, and she's been feeling a little unwell 1 week prior to presentation. She's not been eating well, some nausea, vomiting, no headache, and she presented to an outside hospital with multiple seizures. They documented extensive sinus thrombosis of the superior sagittal bilateral transfers. She was started on enoxaparin. She was transferred fairly quick to us. She got to us within 6 hours. Her exam when she came was a GCS3. Her pupils were sluggishly reactive, but they were reactive for sure. And this was her CT. So this is fairly on in the course. This is about 8 hours, since 8 to 10 hours from presentation. And you can see this brain looks very angry. There's a lot of edema. You can see hypodensities in the posterior fossa. So what would you do in this case? So these are 4 cases I would like to keep in mind as we'll go through the discussion, as I quickly review cerebral sinus venous thrombosis. So the epidemiology, you have to remember CVST is a rare condition. If you're considering a condition like ischemic stroke, CVT is extremely rare. And we don't have very good studies. Most of it is from Europe and Australia, and the incidence is likely underestimated. So for instance, in Netherlands, the incidence is about 1.32 per 100,000 per year. And women certainly higher, 2.78. And in women, of course, the periods of susceptibility are all peripartum. In this US registry, you can see that the increase of CVT during pregnancy is 11.6 per 100,000. And this is fairly reflective in most case series where CVT is more common in women and peripartum is a significant risk. And add to that, of course, OCPs. Having said this, incidence rates are much higher from documented series coming from India or the Middle East or Latin America, and probably has a lot to do with demographics, social cultural factors. So all this have to be kept in mind. Compare this to ischemic stroke and you will see the difference. We are talking about 1:100. So it's a very rare condition. So it affects young people. The median age is about 37, but younger for females. You can see women were 34 as compared to men. And there are very few people who are older than 65 who get this problem. Female to male ratio is about 3:1. And if you're looking at pediatric population, certainly more common in neonates. So just a very brief touching upon the anatomy. So there are the venous anatomy can be extremely variable. So this has to be kept in mind in sharp contrast to arterial anatomy, which is usually constant. So if you look at the superficial, you have the large dural sinuses, the superior transverse sigmoid, and there can be variability in the cortical drain veins. The deep system is relatively constant, and the posterior fossa, again, there can be a lot of variability in how the venous system drains ahead. But if you look at the patterns of venous infarction, so this is pointing to the superficial middle cerebral vein. This is the vein of Labbé or transverse sinus. And then, of course, this is the superior sagittal sinus. If you go deep, this is the deep cerebral veins, and then you see the medullary and subependymal veins. So a very different pattern compared to arterial territories. But even among this, there can be a lot of variability depending on which vein is draining and how there's redundancy in the system. So briefly, this is the pathophysiology. So you have an obstruction of a sinus and there is increased venous pressure. There's 2 components to this. One is that there is decreased absorption of CSF because the sinuses are clotted off, and that increases intracranial pressure. But a lot more happens on the other side when the venulary and capillary pressure are increased, and that is a whole cascade of events which happen. So the capillary perfusion, this cascade, you'll go on to have cytotoxic edema. If there's disruption of the blood-brain barrier, you get vasogenic edema. But I have to say that vasogenic edema is a lot more common than cytotoxic edema. And usually, if you're able to recanalize the vessel, the vasogenic edema is reversible. And at the last stage, if the venous and capillary pressure is too much, then it bursts, and that's when you get a parenchymal hemorrhage. So I'm not going to touch upon what is the etiological workup, etiologies, diagnosis, but I would like to focus on treatment, which is broadly classified as antithrombotic treatments, what you do for symptomatic treatment, and then the etiological treatment. Symptomatic treatment, of course, is anti-epileptics, ICP management, decompression, those things. But the other two, so what about antithrombotics? So both the American and European guidelines do agree that in the acute phase, you need to use heparin. So this is either low molecular weight heparin or intravenous heparin in therapeutic doses. And then after that, you transition to oral anticoagulants. And the duration, although all this is not, what shall I say, it's not evidence-based, but a lot of it is consensus-based. The duration of treatment depends on whether there's a transient risk factor or there is severe hereditary thrombophilia. So anywhere from 3 to 6 months, some clinicians use imaging to help you guide treatment, but usually 3 to 6 months if it's transient, 6 to 12 months, and then lifelong if it is severe. So what are the choices? This is all based on 2 European trials and 2 Indian randomized controlled trials. But the evidence is not so strong. They've done systematic reviews after that. And there's this one data set, which is called the ISCVT, which has a large group of 600 patients. And the consensus is low molecular weight heparin was slightly better than unfractionated heparin. There was better outcomes, lower hemorrhage. And this is also if there is patients who have intracerebral hemorrhage or subarachnoid. So we don't withhold anticoagulation in these patients. And there's not much data for the use of antiplatelets in CVT. So what about outcomes? So this registry with ISCVT, a lot of patients do very well, up to 80% recover completely. But there's up to 13% of patients who are dead or dependent. So certainly room for improving treatment, because not a small portion of patients do have severe disability or die. And these are the predictors of long-term prognosis, which are fairly consistent through most of the series. If you have a deep CVT, if you have hemorrhage on presentation, if your GCS is less than 9, if you have altered mental status, age older than 37, and male gender. These are predictors of long-term poor prognosis. And predictors of mortality at 30 days kind of share the same factors: depressed consciousness, thrombosis of deep cerebral system, posterior fossa lesion. So these are things that you can look at to see how your patient is going to proceed through the course of hospitalization, to see if there is a high-risk CVT. So what is the role of endovascular treatment? So is this just a heroic treatment that we're going to use, or is there some data for its use? I can say that most places now generally reserve endovascular treatment as a last-ditch effort when anticoagulation is failing. But what are the circumstances we can use it in? So there's clinical deterioration or progression of the venous infarction or ICH despite therapeutic anticoagulation. If the mental status presentation is severe stupor or comatose presentations, if there's deep CVTs, posterior fossa involvement, or there are major contraindications to anticoagulation. So either thrombocytopenia or recent GI hemorrhages. These are circumstances where you can consider endovascular treatment. So what are we talking about? So there are many different ways and methods we can achieve endovascular treatment. So let's minimize this. So a lot of this is borrowing from ischemic stroke. So in ADAPT technique, basically we have these large bore aspiration catheters, which we snake up to the face of the clot, and then we apply suction to the clot. And this will recanalize the sinus by progressive suctioning clot out. This is also borrowing from ischemic stroke, where we use stent retrievers, which has been a game changer in ischemic stroke, where we use these retrievable stents to catch the clot and then pull it out. you can use intrasinus thrombolysis. So thrombolysis with different agents has been used for quite a while now, where we give within the sinus boluses of thrombolytics, or we do long-term the catheter in place for about 12 to 24 hours and slowly infuse the thrombolytics. So the usual ones used are urokinase or alteplase, and alteplase anywhere in the dose of 0.5 to 2 milligram per hour for 12 to 24 hours. There is this device called EntroJet, which is basically a very high-speed saline jets which come out from the distal tip of the catheter, and there's another port through which you can aspirate. So using the EntroJet, you disrupt the clot using the high-velocity jets, and then you also aspirate through the port. And then the last one is shown over here. So sometimes in refractory cases, we can blow up a balloon and then just drag the clot down while aspirating. And this has been used in case series. A lot of times they use Fogarty balloons, but other balloons also have been used. So these are the different types of techniques we can use for endovascular thrombectomy. What is the goal? The goal is to achieve some sort of effect in these cases, but even if we achieve heparin to work, it increases the contact surface area for the heparin to work, and then reestablish antegrade venous flow in the targeted sinus, and consequently you're reducing the venous pressure, the venous congestion, and therefore its associated complications. But the important questions are, does EVT improve functional outcome? So there are numerous single center case series which have assessed safety and efficacy. This is one series or systematic review of 185 patients from 42 studies, which was published in 2015. And these were fairly severe cases. So there were 60% with ICH, 47% with severe presentations in terms of mental status. And they reported a very good outcome, MRS of 0 to 2 in 84. There's a more recent one from 2017, which included 237 patients. And again, patients who got some sort of endovascular therapy, up to 76% of them had good outcomes. But in terms of randomized control data, we have just this one trial, which is called the 2-ACT trial, which was published in 2020 and presented slightly earlier. So this trial wanted to assess the efficacy and safety of endovascular therapy in patients with severe forms of CVT. It was done in Portugal, Netherlands, and China between 2011 and 16, and it had to be CVT cases with at least one risk factor for a poor outcome. So they stuck with mental status disorder, severe presentations with coma, ICH, they did not define ICH, or thrombosis of the deep venous system. So you got EVT versus EVT plus standard medical therapy versus medical therapy alone. And this had to be done within 24 hours of randomization. And the good outcome they chose was MRS of 0 to 1 at 12 months. So two things I want to draw your attention is the time frame was 2011 and 16. The devices we used have significantly improved since that time. And they did choose an outcome of MRS 0 to 1. So what did we find? So this was the primary outcome. I have to draw your attention to the number of patients. So this is 33 and 34. So not many patients in both groups. There was hard time enrolling patients over the 7 years. But essentially what it showed that at 12 months, there was no difference in outcome, whether you used EVT with standard therapy versus standard therapy alone. So the graphs look pretty much the same in both groups. What about safety? None of these numbers were significant, but of note, there was more mortality in the EVT-related group. However, inversely, there was less numerical ICHs in the EVT-treated group, although both mortality and ICH did not meet statistical significance. If you look at the secondary endpoints, what about if you take MRS 0 to 2, or what about if you assess it earlier? There was no difference. So if you look at any dichotomization of MRS at 2 time points, 12-month or 6-month, there was no difference between the two groups. But what was interesting was there were certainly higher rates of recanalization in the EVT group compared to the standard medical therapy. However, this study did not assess recanalization immediately after the procedure or short term. This was assessed at 6 or 12 months. But at any rate, the recanalization was higher at long-term follow-up in the EVT group. So this study, they said there was no difference, but of course, this is not categorically proved that EVT does not help. There were many criticisms, very small numbers. They could not do subgroup analysis in terms of categories like ICH presentations, deep CVT, or severe presentations like coma, because the numbers were just too small. And the devices we have now are a lot better at recanalizing sinuses. So is there a limitation with the devices which were used early on in the trial? So multiple factors like this, but to their credit, well-run trial and the only randomized control data that we have. So what is the safety of EVT? So majority of the single center case series, the safety is underreported. But the 2-act trial reported 3 out of 39 patients where there was a perforation, where there was a bleed. And this is likely because of perforation of a cortical vein. A lot of times when you do this procedure, it's blind. So the wire could certainly go into a cortical vein and perforate it. But interestingly, none of the patients in whom a perforation occurred developed symptomatic ICH. And possible an explanation is that the veins are full of clot and the perforations occurred at the beginning of the procedure when things were still occluded. But by and large, the case series do report that it is a fairly safe procedure. So should we do endovascular thrombectomy in conjunction with intrasinus thrombolysis? So we do not know. Is there a concern for ICH if we use intrasinus thrombolysis? So at least from the data we have from the systematic reviews, new or increased ICH was seen in 10% of all the cases, but they were not that much different between the two groups. So this happened in 7% of patients who underwent EVT alone versus slightly higher in those who got intrasinus thrombolysis also. But this was not statistically significant. And the answer is we do not know yet. What are the limitations of endovascular thrombectomy? So, of course, we can go into mostly the big sinuses. So these are the superior sagittal sinus or the transverse sigmoid, maybe even the straight sinus, but we do not get into the cortical veins or the deep venous system. So our thrombectomy efforts are limited to these big sinuses. There are a lot of other questions which we do not know about thrombectomy, which particularly go around the fact of when do we choose our patients? What is the duration of therapeutic anticoagulation before we says therapeutic anticoagulation is a failure? How long do we wait? So I presented a couple of scenarios. Is that failure of medical management and should we pursue EVT? What about ICH presentations? Should we do EVT alone, endovascular thrombectomy, or should we leave a catheter in there and infuse thrombolytics? What about patients with large parenchymal lesions with impending herniation? When do we choose hemicraniectomy over EVT? Or how do we combine hemicraniectomy and EVT in these patients with severe thrombosis? So a lot of questions still remain with endovascular management of CVT. So I'm just getting back to the cases. So case 1 was a young gentleman on therapeutic anticoagulation who had ischemic stroke without hemorrhage, despite being on 48 hours of anticoagulation. So we decided that he was not improving. He had a fair trial of anticoagulation and we took him for thrombectomy. So this is the baseline angiograms, the AP and a lateral view. And you can see quite sparse filling of the sinuses, including the superior sagittal, the bilateral transverse. So this is an idea of how we do it. So our axis is from the right jugular, and then I've gone all around the sigmoid transverse on the right, crossing over to the transverse on the left, all the way down to the sigmoid. And in this case, I used aspiration to clean up this. And then we went to the superior sagittal sinus. So this is an AP and a lateral. And you can see the wires all the way down to the anterior third of the superior sagittal sinus with the catheter to follow. In this case, I did not use intrasinus thrombolysis. We just did aspiration thrombectomy with only partial recanalization. But this was enough for the patient. He actually improved significantly, extubated the next day, and he was discharged in 10 days without any deficits. He made a complete recovery. Case 2 was a patient with 4 days of therapeutic anticoagulation, and he developed a bleed. Again, we thought it was a fair trial of anticoagulation, and he worsened despite that, so he was taken for mechanical thrombectomy. I'm not showing you all the pictures, but showing you some technical difficulties. So this was a right-sided parieto-occipital bleed with right transverse sigmoid thrombosis. So of course, ideally we would have wanted to recanalize the right transverse going in from the right side, but this is the jugular vein on the right side. So it was completely occluded and there was no access to the right system from the right side. So we had to go in from the left. And this was our initial venogram. So you can see the left transverse is just a string and there's no filling in the right transverse. So again, cleaned up the left transverse with aspiration thrombectomy and then cleaned up some of the right transverse. Again, have to point that this was not a complete, it was a partial recanalization. I took the catheter up to the superior sagittal sinus and gave some intrasinus thrombolytics with alteplase. It was just a bolus without an infusion. And this patient stabilized very well. So he left with no visual complaints, but very mild weakness on the left side. He was discharged in about 2 weeks. This was the case 3, was a patient who had the hyperacute bleed while he was in the emergency room without starting any anticoagulation. So we immediately started anticoagulation despite the bleed, including a bolus of heparin. And then we decided to take him for thrombectomy. I'm not showing you the thrombectomy pictures. We did a complete recanalization and we gave a small bolus of TPA within the sinus. But after the procedure, this patient extended his bleed. So if you remember the first pictures, he certainly extended his bleed and he went on to require a decompression. He had a stormy course. He had status epilepticus, required a tracheostomy, peg tube, but was discharged after a month with an MRS of 5. He is awake but not following commands and severe right hemiplegia, but moving the left side. So this patient did worsen his bleed. And the last case, the pregnant woman who came in, it was a severe presentation. As a last-ditch effort, we thought we'll give her a chance. We took her for angiogram, and this was the angiogram pictures where she had severe raised intracranial pressure, which shows up on these pictures where there's very slow filling of the blood vessels and non-filling of a large portion of the cerebral hemisphere. So this patient, of course, we couldn't do anything. We did not perform any further thrombectomy, and she herniated and passed away. So in conclusion, endovascular thrombectomy for CVST is feasible, and it is reasonably safe. I don't think it's a heroic measure in centers who have good experience and good volume of patients. I think it can be used effectively, but patient selection is key, and we don't have all the answers at this time. However, I would suggest using EVT in severe sinus thrombosis cases when there's clinical deterioration despite anticoagulation or their presentation with severe neurological deficits or coma. Having said that, CVT is a very rare problem. Severe presentations of CVT are even more rare. Therefore, routine use of EVT is not justified and needn't be employed in majority of cases. Thank you very much for your kind attention.
Thank you. Thank you, Sebi, for your wonderful presentation. I think both presenters really presented extremely challenging cases, and there is a lot of questions that have emerged, and maybe what we should do is we should start discussing Irtesa's case. And what we should also do is maybe we should discuss as the panelists and read some of the questions of overall interest that were placed by the participants, because we have now 1,200 people, and we would like to keep this educational. So, hey, do you want to start with the questions for Dr. Itesa?
Yes. So first, thanks for both speaker about these cases. Just for the audience, these are a very rare condition that they will see it. And that's the beauty of working with the Cleveland Clinic. I remember the only case, Dr. Teza, that I saw with large B-cell intravascular was in Montreal in 2009 or 8, where a patient presented similar to your case. Progressive neurological deterioration. At the beginning, we thought about dementia, but when the scan has been done, CT, MRI, she had these multiple nodular, there's an echo, sorry, multiple nodular shape, acute stroke involving white matter, gray matter, but she was progressive dementia. Is your patient had the same thing? Or it was different than usual neurological presentation with acute stroke presentation that we have?
Absolutely. So it was a progressive cognitive decline. So very similar patient, but superimposed upon that was these sudden deterioration with gait. And when they saw those cerebellar strokes, they were thinking, you know, maybe she showered emboli. So they were thinking of more of a vascular dementia, multiple recurrent strokes, is what their initial impression was.
Interesting, because it's very weird why with these multiple nodular type of ischemia that it's not acute weakness or acute aphasia. What they're having is the family will bring them with this progressive dementia that she's, and my patient had later stage seizure, then she passed away because of that. But I will say it's very challenging case to get the diagnosis without the biopsy. So there's a few questions that we can start with, and I think both of you read some of these questions. Some of them are relative. One of the audience asked why these are not a mycotic aneurysm, one of the differential diagnoses, Dr. Teza.
So that's a great question. I couldn't show the entire scans, but there was no evidence of microbleeds. So the GRE and susceptibility weighted imaging sequences were negative for microhemorrhages. It's a good question. Interestingly, patients with intravascular lymphoma can also present with multiple hemorrhagic lesions. And so that would be within the differential for, unusual cerebrovascular events or unusual stroke. But in this instance, it was not consistent with mycotic aneurysms. But that's a good thought as for initial differential if you're thinking outside of the box.
And is one of your differential also primary or secondary CNS vasculitis in these cases, despite normal angio?
Absolutely, absolutely. So that's always within the differential, and she was tested for that. And some people actually have lymphoma-induced vasculitis as well. They can coexist. We've also seen amyloid-induced vasculitis. But the pathological specimen was read at main campus in Cleveland, Ohio, and that's a very big center for CNS vasculitis. And they specifically looked for any concomitant vasculitis, and there was none. So this was a pure case of intravascular lymphoma.
Interesting. Did she have other organ involved with the B-cell lymphoma, or it was just the CNS?
So this was categorically just pure CNS lymphoma. There is a predilection for the skin for intravascular lymphoma, adrenal glands, and sometimes some of the sex organs as well. But overall, a lot of times it tends to hide within the CNS, and you have to have a high index of suspicion. Through my literature search, I saw that part of the diagnostics if brain biopsy is not readily available, a random skin biopsy, even of asymptomatic, just normal looking skin, should be carried out, because that can actually pick up cases of latent intravascular lymphoma in up to 80% of patients. So, but intravascular lymphoma can involve other organs, and intravascular lymphoma can also be within the context of CNS lymphoma. This patient on pathological analysis did not show any primary CNS lymphoma. it was exclusively within the intravascular compartment.
And you mentioned about the, sorry, last question about the methotrexate. One of the questions from Dr. Manal, is there any rule for steroid in the management of these cases?
Absolutely. So whenever you're entertaining a possibility of, an inflammatory process affecting the cerebrovasculature, and you're thinking about vasculitis, the classic teaching is don't give steroids, get a biopsy, because if it's lymphoma, it's going to shrink it, right? But we just felt so bad for this particular patient. When she arrived to us, she had been devastated neurologically. This had been going on already for 3 months, that we opted to start steroids initially. And by the second day of steroids, she underwent the brain biopsy. So I would say it happened in tandem. But the classic teaching is if you can delay the steroids, then you should. And then, as you know, the R-CHOP, the P in the CHOP is actually prednisolone. So she was maintained on steroids afterwards.
Thank you. Dr. Deck.
Yes, I mean, this is obviously, as you pointed out, a burned out case at the time when she showed up at your institution. If she would have been diagnosed earlier on a higher rate of suspicion, this might have been different. My question is, and you already said a little bit about this, intravascular lymphoma can be associated with CNS lymphoma. In this case, it was not. Why was MTX intrathecal therapy chosen if it is a truly intravascular disease?
Yeah, so that's why, and I would obviously defer to my oncology specialists, but my review of the literature is that the response rate for primary intravascular lymphoma is better with concomitant methotrexate or cytarabine. And so I think that's mainly an oncology-based decision. I'm wondering if they were considering, because this was brought to our attention, they were concerned that we had started steroids already and maybe we had diminished any concomitant CNS lymphoma. And so I think that was their rationale, and that's the reason they pursued that.
Was this done with a reservoir or with repeated intrathecal lumbar punctures?
I believe it was done through repetitive punctures. She does not have an intrathecal reservoir.
Yeah, amazing case. I'm just thinking of, the question from Dr. Manal, and you also echoed this. Martin Samuels, we probably all know him from the Brigham and Women. His opening statement is always: a patient should never leave, a complicated, complex patient should never leave a neurologist without a steroid. So I think this applies to this case as well. Are there any other questions? I don't see any other questions for Irtesa from the audience. I think this is an amazing case. Congratulations again, and wonderful presentation. So maybe we can swing over now and grill Sebi.
Ready.
Because he has a very, very wonderful presentation. One thing I don't like is you said there's no evidence, there's only consent. I mean, consensus among specialists is also evidence. I mean, it's just a lower level of evidence, and you didn't show us any evidence, because the trials that were done, not only the endovascular, but also the ones for heparin, in particular the one, remember, from Dr. Einhäupl from Munich from 1990 something. I mean, what kind of a trial was that? This was not a trial with the quality that we have today. So I think we really still don't have very good data, and so we depend on people who see these cases a lot. And I really liked your case approach, because that's all we have. And I do not remember all of those 4 cases, but it turned out that, again, earlier is better. So if you identify these cases earlier, then you might get away with things like heparin or low molecular weight heparin if it is better. That might be the case. But what is your personal threshold as to when you consider going endovascular in a patient like this? Do they have to be comatose? Do they have to have status epilepticus? Or what is your personal threshold, Sebi?
Yeah, so that's the whole reason why I presented those 4 cases, because each of that, unlike arterial strokes where you have an occlusion and things are pretty mostly straightforward, we struggle with this actually. Although I presented these cases, the brainstorming which goes before each of these cases is quite difficult. So the answer for your question is I don't know, but if we truly have given them a good 48 to 72 hours of therapeutic anticoagulation and they don't recover clinically, as in the first case, he was still comatose, or they, despite that, start having bleed, I think that's a fair trial to consider endovascular options. Irtiza did a case just today and yesterday. This lady has GCS 15, and I sat on her, but every scan you do is worsening edema, worsening edema, worsening edema. And then we were like, we have to do something. Otherwise, she's going to deteriorate. But oftentimes these answers are not so clear cut. So it depends on each institution and your comfort level with taking them. And of course, the support of a full neuroscience institute, including ICU, neurosurgery, for very, very careful management of these patients.
Mm-hmm. There's a question from the audience, from Dr. Gufran. He's asking, what was the etiology in the cases that you showed? Did you find out?
The first case 1, there was no etiology. I think he just landed. He started his job, was dehydrated. Case 2 was protein C and protein S deficiency. Case 3, we did not find any etiology, and case 4, probably, she was 6 weeks pregnant. So the hypocoagulability related to pregnancy.
Mm-hmm. And then there's another question from an unidentified attendee is asking, what is your opinion on endovascular thrombectomy in aged patients, so in elderly patients?
Arterial or venous?
It doesn't say. I would say venous. That was your presentation.
I would still stick
or
by.
Maybe you give us your experience on both, because I think it happens is of more significance in the arterial tree. So why don't you?
Okay, so I'll start with the arterial. We have very strong data in sharp contrast to the venous side. On the arterial, we have plenty of randomized controlled trials. And no matter how you slice it or dice it, no matter what subgroups you take, endovascular thrombectomy helps almost every group, even including the elderly. So the patients even above 80 or 90, I would say they would benefit from endovascular thrombectomy. On the venous side, it's usually much more rarer. Like I said, there's only about 8% in patients over 65 years of age. But I would probably use the same principles. If they're not responding to medical therapy, I would try to salvage using endovascular.
Can I ask you, Sebi, how many cases, you probably have a database on those, have you done at the Cleveland Clinic since you joined?
Not that many, actually. As we were talking about it today, they come in waves. But I would say less than 10. Less than 10.
And what kind of you talked about the procedures in theory. So there is physical clot extraction, either with a stent retriever or with a suction device, and then there is thrombolytic therapy. And you showed this one example where the bleed extended with thrombolytics, which I think is coincidental, because I mean, it's a venous infarct and not an arterial infarct. So I think this is unfortunate. This may have happened anyway. But how would you, this is one question also from the audience, how would you explore a little bit on what you would use in what cases? When would you do pharmacological versus physical retraction?
Yeah, okay. So I guess it depends on the degree of recanalization. So if clots are not that organized, if the patient has a fairly recent history of headaches, you would presume that these are fairly fresh clots, and therefore it is easier to advance our devices. So if you're able to get through to the sinuses reasonably, then you can just deal with aspiration thrombectomy or a stent retriever thrombectomy. But if your recanalization rates are not good using these methods, I would certainly consider either giving a little bolus of TPA or leaving a catheter in there. So I would base it on the degree of recanalization. If you've already achieved an excellent recanalization, then I don't think there's additional need to give thrombolytic. The second one is we just can't get our devices up there. So we can't get our large bore aspiration catheters, but we may be able to snake a microcatheter through. So in this case, we only have an option to give thrombolytics.
Irtiza, do you have something to add there?
No, I would echo Sebi's sentiment. So as he was saying, we just did a case over the last 2 days of a chronic venous occlusion, acute on chronic. And the first day we could not get a catheter in, so we put a microcatheter in and we infused TPA overnight. So the patient remained intubated, sedated, paralyzed, and we infused TPA at 1 milligram an hour into the sagittal sinus. And the next day when we went back, there was enough of a channel that we could now get our catheters in there and carry out thrombectomy. So I think we have to kind of tailor it to the situation. I think acute thrombus, as Sebi showed, opens very nicely with mechanical disruption. But once it becomes organized and chronic, then I think there is a more role for thrombolysis. And I'd like to echo Dirk's sentiments that I think it was unfortunate, but TPA in this instance is it's a concomitant factor. I don't think it's the etiology. This patient was actively deteriorating and bleeding. The hematoma developed within 60 minutes, the first and second scan. So the fact that the hematoma continued to expand, I'm not surprised in that scenario. But I was hoping that if we could ask both you as part of our panel, what's your process? And I think the main issue that I sometimes get not annoyed, but kind of disgruntled with is when patients have not received an adequate trial of anticoagulation, as defined by reaching a therapeutic level, getting the right dose. A lot of colleagues will shy away. And I think, if anything, if we can use this platform today to educate all our colleagues that, as Sebi pointed out from the ICVST trial, the presence of hemorrhage on a scan in the context of CVT is not a contraindication for anticoagulation. You have to treat these patients aggressively up front. And I was just wondering what your practices are. Sohail, Dirk, would you like to weigh in on this?
Go ahead there. Go ahead.
What I can say is I absolutely agree with what Teza just said. I mean, this is in particular for the 1,200 people that are listening. It's really, really important. These venous infarcts, they are not arterial infarcts, and you don't have to shy away from using anticoagulation. You should use it in the dose that is appropriate for the case. What I would like to say, and I would also like to elicit a response from both of our speakers, and that is, when I was in Copenhagen, we were the national referral center for sinus venous thrombosis. And if you are the national referral center of 5 million people living in Denmark, and all of these sinus venous thrombosis come to one center, then you actually end up with a few cases. And so we actually had more venous infarcts than arterial infarcts. This was in 2008. When there was no yet thrombectomy for arterial lesions appointed in Copenhagen, but we had probably 1 or 2 a month. And what we did is, again, the technology was not there yet. And so we ended up in most of the cases using intravenous catheters, multi-lumen intravenous catheters, the same ones that have been used in the DVTs in the old days. And we left them in the patients for 24 hours, repeated the angiogram and so forth. And I must say, what struck me was and Sebi pointed to this, the variation of the venous anatomy. But there's one other thing. If you do sequential venous angiograms, they never look like the same because it depends on the pressure. It depends on how much you inject, how you inject. And it's very, very difficult to quantify this. And I remember one case. It was a young woman who was in her 20s and had this horrible deep thrombosis, which we for us was a red flag of using intravenous thrombolysis, and so we had this patient for days, and it looked the same, and it was still looking very, very bad in terms of the venogram. And then we said after a week or so, we have to wake her up and have to see what's going to happen. And believe it or not, 2 days later, she was awake. So by just, and Irteza alluded to this, by just changing the venous anatomy just a little bit, you can actually drain this whole thing and you treat the case. So I would like to hear what Sebi and Irteza say to this notion.
Absolutely, we were just talking about this today, and we were looking at Sebi's cases for this presentation, and we don't shoot for perfect pictures. As long as the brain is draining, and we usually have a catheter on the arterial side, and we're looking at transit times. If the hemisphere is looking relaxed and we have antegrade flow and there's significant recanalization, the goal of endovascular thrombectomy and CVT is just to reestablish outflow. It can be minimal outflow, but that's the goal. And as long as the transit time looks better, you don't have to go shoot for perfect pictures. And that's usually what we shoot for. And then obviously we continue medical management with anticoagulation. Yeah.
Sebi?
Yes, and just to add, you're just creating also, I feel, channels for the heparin to work on. If there's no surface for the heparin to work on, then it's not going to promote any more recanalization or prevent extension of thrombosis. So the little channels that you create will eventually extend into the cortical veins. And like you said, there's so much redundancy and so much variation. Maybe just one little thing which opens up, and that'll be enough for the patient.
If I will add something here, Derek, regarding our experience at Rashid Hospital. We just published a paper descriptive about our series of CVT, which is almost more than 150 plus patients from Rashid Hospital by Dr. Jaweed, Pornami, and Maria. Plus, Maria published her paper about using NUAC in CVT patients from Rashid. One of the things that it's very rare condition. I remember being at Montreal for 7 years. Per year, we will get 1 to 2 patients maximum, and there will be a grand round about that patients to speak about venous thrombosis that we don't see, which is a rare condition. At Rashid Hospital, we are getting per year between 25 to 30 patients CVT. In early 2012, 2013, we were giving at that time IV heparin, which was patients need to admit to the ICU because of doing coagulation profile every couple of hours to take the right decision about the level of heparinization. I remember for the last 5 years, everyone will be admitted to high dependency stroke unit, not to the ICU, sub-Q heparin, 60 BD or 80, whatever, depend on the weight, and rarely will have a complication with that. With those patients who's coming with intracranial bleed, as Sebi showed, it's very safe. Rarely patients will have any complication with full anticoagulation of these patients, but we tried to avoid admitting these patients to the ICU because there were we having the anticoagulation protocol for intravenous heparin. Second thing, just as you are mentioning the cases, we admit a recent patients with bilateral thrombosis of jugular vein, internal jugular, bilateral sigmoid, bilateral transverse, superior sagittal. There's nothing. And the patient was full puffy swollen face because it seems everything is drained extracranial. How? We are not sure, but when we did the CT angio, his face was like an apple, tomato, okay? Full anticoagulation, patients went home walking, not intubated, nothing is there. We did with Dr. Ayman Al-Sibai in 2013, maybe 4 cases. Maybe the devices at that time was not the best, but we didn't have a good outcome with these patients. One patient had a rupture. 3 of them didn't have a good recanalization. Suction wasn't there available at that time, I believe, for the interventionist. We found very rarely that we were required to do any intervention for these patients. Before I forget, Mr. Ahmed, one of my patients, local 21, Irtiza, he was full thrombosed. There's no single vein was draining there. Intubated, ventricles was compressed bilateral, nothing is there. I spoke with the neurosurgery for decompression. They said, Suhail, no hope. I spoke with the mother. The only time that when I spoke with the first time to do this mistake, that unfortunate mother of Ahmed, your son is very critical. I don't think he's going to survive. But we didn't stop the anticoagulation. We continue on anticoagulation, full hydration. After 21 days, extubated, the boy is coming once a month to say hello to Dr. Suhail. There's mild mental insult was there, walking independent, driving his car on anti-epileptic, wonderful. So the CVT pathology is totally different than others. If you treat these patients with good anticoagulation, good hydration, keep them on those doses. If he required to be intubated, maybe we need mechanical thrombectomy, intravenous TPA between 2 brackets. But I remember for the last 5 years, 6 years, we didn't do any intervention. We didn't require that in Rashid Hospital. But very interesting cases. There's one question to Dr. Saeed Irtiza, Derek, as we are getting close to the end. For the intracerebral lymphoma, Dr. Irtiza, what's the possible of diagnosis by CSF analysis from Dr. Abdul Karim?
Yeah, that's wonderful. So if we go to the olden days where, malignancies were diagnosed by CSF only, and you look at that literature, the sensitivity of a single CSF sample is very, very low. I think it was below 30%. When we add, that's just looking at cytology. If you add flow cytometry and then spin for it, you potentially may increase the sensitivity. But in intravascular lymphoma, by definition, usually you don't have significant cell presence within the CSF space. This patient was tapped in the native country. There was no pleocytosis. When we tapped her, she again only had 2 cells. So the yield for a intravascular lymphoma may be low. Now, where we have to separate this from people who have CNS lymphomatosis, right, or basilar meningitis, or what we would say leptomeningeal lymphomatosis. That's a completely different animal, and there the yield may be more so. Nevertheless, we did do a CSF analysis as part of our vasculitic atypical inflammatory workup, and everything came back negative normal. So again, you can do a CSF sample, but I think the money is on the biopsy. You have to go to the biopsy.
Dr. Sebi, there's one question regarding decompressed trial and decompression and CVT. Anything to add there?
Yes, certainly. If you have large lesions, herniations, or bleeds, you have to decompress and then continue anticoagulation. I don't think there's a trial. I'm not aware of a trial on it, but I would say that if mass effect is a significant problem, then you have to decompress and then continue anticoagulation.
Good.
I wanted to say something about this too, because we still have 1,200 people with us, and this is very important, you know, from an educational perspective. You know, we tanked these people with heparin, and then all of a sudden we asked the surgeon, please do a hemicranectomy. This sounds counterintuitive, and I'm sure that a lot of neurosurgeons will say, no, I'm not going to do this. But as a matter of fact, I mean, there's, as Sebi just pointed out, there's no controlled trial or not even large series, but the people that I oversee in Copenhagen, and we've done it also in Heidelberg, because after all, I'm from the Hacker school, and the decompressive surgery was always very, very close to us, and I've seen wonderful results. And I think it has to do also that you give, you change the compliance and you increase the venous flow, even if there's everything is thrombosed. The collaterals through the labes and through other areas, and so maybe even extracranial. So I think this is something that I would like the two panelists from Cleveland also to tell us that the hemicranectomy, or even bilateral hemicranectomies in these patients where only the sinus is covered with calotte, is actually an option in cases, and we have to decide when we're going to use this. Please.
Want to go, Ortiza?
Go ahead, my friend.
Yeah, like you said, we need buy-in from our neurosurgeons. So I would say, especially for young patients, if it is unilateral, we often push them for sure to do a hemicranectomy. For the bilateral hemicranectomy, it's been many years since I've had a patient who we've done a bilateral hemicranectomy. But I would say for a one-sided hemicranectomy, I have no reservations in asking my neurosurgeon to do it.
Yeah, and I agree, and that's been our practice here. So some of these saves that you've seen here today, a lot of those saves have involved early surgical decompression. So the heparin is on, literally is turned off as the patient's going to the OR. They may give some protamine just for the purpose of the surgery. Once the surgery is done and they have good hemostasis of the wound, heparin is restarted. And I agree, Dirk. I think sometimes when you're on that, the compliance is, you know, where everything is so tight that now the elevated ICP from the vasogenic edema in itself is perfusion is failing. And sometimes just opening up that box in addition to anticoagulation is what's required. So we've seen many patients over the last couple of years who've really benefited from hemicraniectomy within CVT. And with CVT, you know, when you're in the midst of the storm, it feels like all is lost. We've all had miracle stories where patients have walked back, just like Sohail has said, and Dirk. And you know, and it's so rewarding when you see that, because you know they were in such dire straits and everybody would have just written them off. But I would argue venous thrombosis is a different beast, and if you can buy them time, somehow blood flow is redirected, and I think that's a key point in this.
Great. Well, thank you very much for this for these assessments. I think this was very interesting and educational to talk about venous thrombosis rather than arterial thrombectomies. Sohail, do you have any final words?
Okay, thank you. It was a wonderful 90 minutes for both speaker and for the co-chair. I would like to thank Professor Said Irtiza, Chairman of Neurology at Cleveland, Abu Dhabi, and our new friend, Dr. Sabi Jones from Cleveland, Abu Dhabi, neurointervention neurologist, and our co-chair, our Professor Derek Krieger from Dubai. The CME hours will be sent to all of the attendees within 2 weeks after the presentation. This presentation is CME, 2-hour CME accredited there. It's endorsed by WSO, American Stroke Association, and organized by the MENA Stroke Organization. We will see you next month. We will have a group of speakers from the US with us and from Saudi Arabia. So wait to see all of you in few weeks. Thank you both speaker. Thank you, Dr. Derek.